Everyone, welcome to the COVID-19 infectious diseases office hours today. We're really happy to see everybody. Just a couple of housekeeping announcements before I introduce our hub team. For those of you who have never joined us before, we really love to see people's faces. So if you have a camera and can turn it on, we would love to see that. We would ask that you please put your questions into the chat box and keep yourself muted otherwise, unless we ask you to unmute yourself. And we would also ask that you not answer the chat questions unless you're a member of the hub team, or we ask you to answer the question in the chat. So we reserve the chat really for questions that you have regarding the presentations and whatever questions you have today. So we're really excited to see everybody today. We have everybody on. We have our Nestor Sosa from infectious diseases. We have our colleagues from public health and primary care, and I'll introduce them one by one and they'll give their updates and then we'll go directly to the questions. And I'm Carla Thornton. I'm infectious diseases physician here at UNM and one of the associate directors at Project ECHO. So again, welcome everyone. And I'll turn it over to Nestor, who can introduce himself and give you his, show his slides.
Thank you, Carla. Hello, everyone. Let me share my screen and start with my update. Today, my update is going to be slightly shorter because we have, I think, more than one presentation. Let me put this in this big screen. All right, so let's start. So the first paper that I'm going to mention is it's something that we have been discussing since the beginning of the pandemic. Those patients that develop COVID and then persist with positive SARS-CoV-2 PCR, are they contagious? And we have been saying, based on some earlier data from Korea and some more information gathered by the CDC, that they are not. But there was recently a publication about transmission from these persistently positive SARS-CoV-2 or PCR positive SARS-CoV-2 patients, precisely from the NBA, from the National Basketball Association. So I found it nice that they conducted this study. As you know, they did this bubble in Orlando in which they conducted a large part of the basketball season in this special area with some special conditions, so they were able to study this. So the article was published in JAMA Internal Medicine, and the title was SARS-CoV-2 Transmission Risk Among NBA Players, Staff, Vendors Exposed to Individual with a Positive Test Result. This was a pretty large bubble of 3,648 subjects among players, coaches, vendor, etc. And 36 of them had a persistently positive PCR when they were invited into the bubble. They actually completed their quarantine as per CDC recommendation. They recovered from their disease, and then they were allowed to be in the bubble despite the fact that they had a positive RT-PCR. And they basically stayed there for the 100 days of that shortened season. They had, it was in total like a 1,500 person day of direct exposures. And guess what? None of these positive PCR produced any secondary cases. So 0 secondary cases in this cohort. And this graph basically illustrates, these are the 36 positive. These circles are when they develop the disease. They obviously have to wait, between 20 and 30 days to actually be invited into the cohort. 0 is the time when they were invited, and all the orange are the moments where they had a positive PCR. So quite a significant number of positive PCR while they were in their participated in this sports activity, and as I said, 0 secondary infection from those with a positive PCR. So I think this very elegant study from the NBA actually proved that those late PCR positives are probably just remnants of RNA and not really viable virus. So it was good to see this data. So in this retrospective cohort study, and this is the conclusion of the authors, study of the 2020 NBA closed campus occupational health program, recovered individuals who continue to test positive following discontinuation of isolation were not infectious to others. And that's really a reassuring finding. The second question, we continue to accumulate evidence on the effectiveness of the mRNA vaccines in preventing COVID. And this study that I'm going to mention, it's real life, so it's effectiveness, not efficacy, in patients and in hospitalized patients over 65 that we know from our knowledge of other vaccines, especially influenza and others, that the effectiveness in older individuals tend to be lower. So these authors actually study the Pfizer, BioNTech, and Moderna vaccines among a cohort of a group of hospitalized adults more than 65 years in different hospitals. They actually studied 24 hospitals, 14 states in the US between January and March that were vaccinated. And they actually did like a case control study in which cases were those with COVID and control were those with no COVID, other diagnosis. And they actually looked back at their vaccination status. And the main finding of this study, and these were elderly individuals. The median age was 73, and the inclusion criteria, as I said, was older than 65. And what they found is that the vaccine prevented hospitalization in fully vaccinated subjects with a 94% effectiveness, 64 after just one dose. So it was really sort of a confirmation of what we have seen in the clinical study and how we have observed in other studies in other countries with this mRNA vaccine. And they actually did sort of a graph showing the effectiveness, and they classify them if they have only one dose or both together, partial and complete vaccination and complete vaccination. So those who are fully vaccinated, which is defined as more than 14 days after the second dose, had a very close to 100% efficacy, as I said. And after one dose, so with partial vaccination, the protection was around 60%. So this is real life data, and in very or in elderly individuals, not a whole different group age, but actually the most vulnerable. So it was a good reassuring studies, and this was published in the MMWR. The other couple of studies that I'm going to mention, it's something related to what is the effect of vaccines on patients who have already been infected with COVID. So how many doses do they need? We still are recommending, I think the CDC is recommending 2 doses for those who already had COVID. But
just trying to get it quiet. I don't even have, oh,
there is
that worked.
there is a lot of information accumulated that maybe just one dose. So we'll see this study. And also there's also the question of when should I get the vaccine? And this is the first study that I see that actually look into that question. If you had COVID, when should you be vaccinated? And there's 2 schools. There are people who said you should be vaccinated as soon as possible, because every opportunity is a good opportunity to vaccinate. So if you have a patient who had COVID and you have the chance of recommending the vaccine, you should do it right there. And there are other experts that actually recommend like 3 months. So because you're protected for several months, you should wait, or it's better to wait 3 months. So it's interesting, this study that I'm going to show, try to analyze this question. And finally, if you had COVID and you're vaccinated, do you have improved protection against the variants? And there was a study showing improvement in protection against heterologous or different variants to the one that you were infected with, in this case the UK and the South African. So let's see the study. So the first study was basically SARS-CoV-2 antibody response in person with past natural infection. So these were COVID survivors who were vaccinated, and they were compared with those that were not vaccinated. So they took 100 healthcare workers, 38 who had previous COVID, 62 that did not have previous COVID, and they apply 1 dose of the vaccine, and they actually measure antibodies and neutralizing antibodies 10 days after the first dose for those infected previously, or 10 days after the second dose for those who were uninfected or never had COVID. And they compare, and they found, first of all, the antibodies, the general antibodies were very similar in the 2 groups, those fully vaccinated and those with prior COVID with 1 dose had a very similar level of antibody. When you look at the neutralizing antibodies, the group that had been infected before was higher. So even higher than those uninfected who got 2 doses. So this is another evidence that probably if you had COVID with 1 dose, it's enough. Although, as I said, I don't think that the recommendation has changed, but this is another study that supports just one dose for those who had infection, and you can make the argument that it was a higher level of neutralizing antibody after just one dose if you had previous COVID. The other part of the study was actually they stratified the patients between if they got the vaccination 1 to 2 months after COVID, 2 to 3 months, or more than 3 months after COVID. And you can see the neutralizing antibodies tends to be slightly higher if you waited more than 2 months. So if you get the vaccination very soon to your infection, you probably are not mounting such a good response. So this, although there was no significant difference, there was a tendency or a trend towards a better response the longer you wait, and obviously that had to do with the time you need to give the immune system to really receive a boosting. So interesting findings. So I don't know if it's going to change the decision, but at least shows that if you wait a little bit, 2 months or 3 months in this case, there's a better neutralizing antibody response, almost one dilution better than receiving the vaccination between 1 and 2 months after you had COVID. So I thought that was interesting. And this is the other study. It was a much more complicated immunological study looking at how prior SARS infection it's stimulated by the vaccination, and that protection actually it's better against the other variants. And let me explain this. This graph looks complicated, but it is not. So we have SARS-CoV infection here. So if you didn't have COVID and vaccination, so there's 4 type of participant. One who didn't have COVID and were not vaccinated, obviously had no antibody, no neutralization. Those against, let's say, the UK, and this is the South African. Those who had COVID had some cross-reacting antibodies against V117. Those who didn't have COVID and were vaccinated had some. But look at the people who had COVID and were vaccinated. They basically have a very, very high antibody response against this. And these were patients who were infected with the Wuhan, with the original variant. They were probably infected during the first wave. But interestingly enough, when they were vaccinated, now with the mRNA vaccines, they had a very robust immune reaction against these heterologous or different variants. So it's another reassuring data and really surprising to some degree that if you had COVID, you need the vaccine. And that's basically the conclusion. Definitely, you need to be vaccinated if you had COVID. If for no other reason, because with the vaccination, you're going to mount a good response even against these other variants that you were not infected with. So I found very interesting. And there were a lot of other findings in this study, very complicated. If somebody wants to read it, but it's interesting how just vaccinated a person with prior COVID produces antibodies that are neutralizing against even variants that they have not been infected with. So I thought it was important. And just a short report on desensitization with the second dose. On Moderna, this was a case report. I rarely bring case reports here, but I thought it was interesting that it can help some people who are allergic. So what these authors did, and these are a group from Rochester, New York, and they have been working on penicillin allergy. So they have very, very strong allergy and immunology department. They actually reported 2 cases, 2 females who had a reaction, an allergic reaction, one 64-year-old and a 39-year-old woman who had, both of them had allergic reaction to their first dose of the Moderna vaccine. And they for reasons, they decided to receive the second dose. And what these immunologists or allergists did is that the second dose, they did like we do with penicillin, they did a desensitization. So they gave them a small amount. They split that second dose in smaller amounts every 15 minutes, and they were able to vaccinate them without a significant adverse reaction. And they basically reported this experience in the Annals of Internal Medicine. So it's something that in some cases, if you really need to vaccinate somebody, maybe a healthcare worker who had a reaction and they want to receive the second dose, this is a possibility, especially under the supervision of an allergy and immunology. So I found it interesting because there are a significant number of persons who have received an mRNA vaccines and are afraid to receive the second dose because they had an allergic reaction with the first. One caveat, these were not anaphylactic reaction. There were actually, like in this first patient, she had generalized pruritus, urticaria, and some tachycardia, but no hypotension, and the same situation with the second patient. So they were allergic, but non-anaphylactic reactions. And just to finish, I strongly recommend this article. It's actually more of political and social science. It's called Anti-Intellectualism and the Mass Public Response to COVID-19. I think it helped me understand some of the reactions of both decision makers and the public regarding experts and recommendation from CDC, et cetera. So I thought it's from a group in Canada that actually did a study and surveys measuring these so-called anti-intellectualism, which is basically rejection of experts' opinion and recommendation from experts. So I found that very interesting. That's it. Thank you.
Nestor, before you take your slide,
Yes,
can
sorry.
you just put your slides back up for 1 second?
Yes.
Harry Seibel has a very specific question about one of your slides, so I just thought it'd be easier to keep it up. And Harry, do you want to ask your question about the? Yeah.
Sure. It was back on the study about effectiveness of Pfizer and Moderna vaccines, and you put a graph up about different populations in there. I believe it is the one near the bottom that we can, that one. So that appears, where it says less than 14 days, appears to cross zero. Can you comment on the meaning of that piece of data right there?
Well, I think these are like the because these are relatively small number of subjects, are the confidence interval, what you see. So yeah, so the confidence interval, obviously, with the numbers are so small. In this case, in the case of those who had the first dose and had an infection, crosses zero, because the protection is non-existent at this point. It was really very close to the vaccination. But these like large black lines are the confidence interval. And in fact, in general, they commented because the number in this study were really small, the confidence interval were kind of broad.
I just wanted to make sure I was interpreting that confidence interval on that lowest one correctly. So thank you very much for.
Right. Yeah. So that's the case. So in this case, you can argue that there was a lack of protection of the vaccine in such a short period after the vaccination, and it's true. I mean, you can have infections if you just if you were incubating the disease before that.
Perfect. Thank you so much. Thank you so much, Nestor. I'm going to go ahead and turn it over to Leslie Hayes. Leslie, if you can introduce yourself and go ahead and share your slides. Thank you.
Hi, Leslie Hayes, Family Medicine Española. Right, and I'm just going to be doing a couple things on the update. And I'm going to start with, I don't know if the rest of you have been getting as many people telling you or asking you if the COVID vaccine is causing menstrual problems in women, but I wanted to look at that. And it's hard to say what's been the dumbest thing in the pandemic so far, because there've just been so many possible things vying for that particular honor. But this one was ranked up there. This you probably all heard of the Miami private school that told their teachers they couldn't get vaccinated. If they were vaccinated, they're not allowed to interact with students. And the particular reason that they gave was a statement from the person in charge. Anecdotally, tens of thousands of women all over the world have recently been reporting adverse reproductive issues simply from being in close proximity with those who've received one of the COVID-19 injections, such as irregular menses, bleeding, miscarriages, postmenopausal hemorrhaging, and amenorrhea, complete loss of menstruation. No one knows exactly what may be causing these irregularities, but it appears that those who have received the injections may be transmitting something from their bodies to those with whom they have come in contact. Until more is known, we must err on the side of caution when it comes to the welfare of our students and the school team. So most of my patients and friends who have been asking me about this have not thought that it was due to viral shedding from the vaccine, fortunately. But I have had many people asking about menstrual irregularities from the COVID vaccine. And so I was going to look this up, and then this wonderful blog post by Caitlin Jedalina, who is also known as Your Local Epidemiologist, came up, which really just answered all of my questions. So most of the information I have is going to be from her. So as to the question of, is the COVID vaccine causing menstrual irregularities? The simple answer is we just don't know. The initial studies didn't pick this up, but medical studies often are not great at looking for issues that only affect women. So it's entirely possible they didn't pick it up in the initial vaccine studies because they didn't look. So there are some valid hypotheses about what could be causing this. It could be a transient immune response, certainly stress and anxiety related to COVID-19, or the vaccine may be disrupting the menstrual cycle. If the vaccine interferes with your body temperature or disrupts your sleep, that can also certainly interfere with your menstrual cycle. It could be random. It could also just be what we call recall bias, which is when you have something happen, you're going to be a lot more likely to attribute to something that just happened right before. So some invalid hypotheses. The vaccine is not affecting fertility, and I'll go through that in a couple more slides. One that I just find very amusing is that this theory that the spike protein is somehow getting into the bloodstream and then into the uterus and is puncturing the endometrium. The spike protein really is not getting out into anyway, but even if it was, it's way too small to puncture the endometrium and cause bleeding. And again, there's absolutely no viral shedding from the vaccine that would cause menstrual irregularities in contacts. And these are slides from a presentation I did in January, and we have a lot more data now that's really backed this up. But there was a lot of concern that the COVID vaccine would cause infertility because the spike protein contains similar amino acid sequences to the protein syncytin-1, which is a vital protein in the placenta. This would cause autoantibodies to attack the placenta. And really, this has not been shown to be true at all. All the studies of the COVID vaccine during pregnancy have shown that women are really quite able to maintain a pregnancy. And because COVID mRNA vaccines are not composed of live virus, they are not thought to cause an increased risk of infertility, first or second trimester loss, stillbirth, or congenital anomalies. And then last itself is COVID itself does actually cause menstrual irregularities. They did a retrospective cross-sectional study with clinical and laboratory data from 237 women of childbearing age who were diagnosed with COVID. They retrospectively reviewed it. They got menstrual data from 177 patients, and blood samples from the earlier follicular phase were tested for sex hormones and also anti-Mullerian hormone, which is one I've never used, but I guess is a fairly good indicator of how robust your ovarian function is. And of the 177 patients with menstrual records, 25% presented with menstrual volume changes, 28% had menstrual cycle changes, mainly a decreased volume and a prolonged cycle. And the average sex hormone and anti-Mullerian hormone concentrations of women of childbearing age with COVID-19 were not different from those of age-matched controls. And if you want to participate in research about this, any women out there who have ever menstruated, you can do this. So I'll leave it up for just long enough for Kent to do it, but it's just a quick survey about whether or not the COVID vaccine affected your menstrual cycle. And hopefully we'll get some actual data from this. So. And then this was kind of a cool article. This was skin reactions after the vaccine. And this is just a provider-facing registry-based study where they said to all providers, if you have a patient with a skin problem after the vaccine, please let us know. And so they got 414 reports between December of 2020 and February of 2021. Since it's a registry and not any sort of prospective or even retrospective study, we can't necessarily draw a conclusion from the fact of the Moderna versus Pfizer, but nonetheless, I would venture a guess that Moderna is causing more skin reactions just because it's 83 versus 17%, which is a fairly large discrepancy. By far and away, the most common reaction was the delayed local reactions, which we've discussed in detail. Local injection site reactions were also common, urticarial eruptions and morbilliform eruptions. 43% of patients with first dose reactions experienced a recurrence after the second dose. And there were less common reactions such as pernio or chilblains, which you can get from COVID, cosmetic filler reactions, which I think most people have heard of. Zoster was not uncommon, herpes simplex flares, and pityriasis rosea-like reactions. And their conclusion was the cutaneous reactions to COVID vaccine are generally minor and self-limited. They should not discourage vaccination. And I loved this time course. So with the first vaccine, so the purple are the local site reactions, and both of the time those occurred within the first day. Urticaria actually occurred out to around day 3, which I thought was interesting. And same thing with the morbilliform, which is the red bumps all over the body. The delayed large local reaction after the first vaccine generally occurred around day 7. And then I can never say this one, erythromelalgia, which is the palms turning red. And this also occurred about day 7. With the second, everything was much quicker. The local site reactions and the erythromelalgia, forget it, I can't do that one. Both occurred around day 1, and the other ones occurred around day 2. And if you look, almost all of the reactions occurred more commonly in women. 94%, 89% female, 88% female, 93% female, 92%. Mostly in women, average age was 38, 47, 40, 39, 44. I have no idea back in December and January and February what the average age of people being vaccinated was, if that's high or low for that one. The local reaction and the delayed reaction both occurred only in the vaccinated arm. Otherwise, the urticaria and the morbilliform were arms, trunks, and legs, and the erythromyalgia, I hate that word, was arms, face, hands, and feet. And information about both vaccine doses was available for 43% of the cases. 21% had reactions after the first dose only, 63% had after the second dose only, and 16% had reactions after both doses. So of people who had a cutaneous reaction with the first dose, only 43% actually had a reaction to the second dose. And of people who reported a reaction after both doses, 28% said they had a similar reaction both times, 28% had a lesser reaction the second time, and 45% reported a more robust reaction to the second dose. So the skin reactions are common. We don't need to worry about them, and they'll resolve and may not recur with the second dose if they got it after the first dose. And that is everything I had.
Great, thank you so much, Leslie, really interesting. Let's go to Marla Sievers from the Department of Health. Marla, can you introduce yourself? And I don't know if you had any updates for us today.
Sure. Hi, everyone. Marla Sievers, an infectious disease epidemiologist with the New Mexico Department of Health. I just had 2 quick updates. One is that we have published a pediatric case report on our website. I know people have been interested about what has happened with pediatric cases over the course of the pandemic. And if you haven't seen it, we have a series of weekly epi reports that are posted on the website. And this week we added a pediatric case report. Because of the lower numbers of cases, that's only going to be updated monthly rather than weekly at this point, but it is up on the website. So take a look at that, it's there. One other piece of information is that later this week, we are expecting to also publish a variant report that will be up on the same website. So again, that'll be a public epi report that people can look at that's going to look at the variants of concern in New Mexico. And so if that gets published later this week, what you'll see there is that we do now have a handful of the P1 variant cases that have been identified in New Mexico. So that's the so-called Brazilian variant. And what's notable about this handful of cases is that none of them had international travel and they're not epi-linked. So meaning, you know, this isn't a group of cases that are all from the same household or workplace. They're more disseminated than that. So this is not surprising. Texas, Colorado, Oklahoma, Arizona have had P1 circulating since back in March. So not surprising that we're now seeing a handful of that in New Mexico, but that'll be included in the variant report that goes up on the website, hopefully later this week. And that was all I had today.
Thank you so much, Marla. Marla, while I have you, can you just go over the mask mandate, the mask instructions now about when you can and should and should not wear a mask in New Mexico?
Yeah, there's a great infographic. It's much harder to put into words. I think the infographic is kind of the easiest way to look at it. And, you know, basically, so vaccinated people who are outdoors, participating in activities like exercising, you know, or they're with other vaccinated people, doing small outdoor activities don't need to wear a mask. If you have a mix of vaccinated and unvaccinated folks, masking is still recommended. If you can't maintain distance and you're going to be in close contact, people should still wear a mask. But let me look for the link in, and I'll put it in the chat, because probably looking at it in an infographic is much easier than me trying to explain it. I will just say sort of my personal bias is that, you know, until we really have brought an end to the pandemic and we have better vaccine coverage, I think, you know, masking should be a social norm. And that kind of having this patchwork of recommendations, I think, makes it difficult. You know, when you're walking into a situation, you're not going to necessarily know who's vaccinated and is not vaccinated. So I would encourage everyone to wear a mask and take all precautions unless they really know that they're with a group of vaccinated folks in a fairly low risk situation.
Thank you so much. We'll look for that in the chat. I wanted to go to Carissa Colbraith from Tricor and have her introduce herself. And Carissa, I don't know if you have any updates for us today.
Hi, Carissa Colbraith from Tricor Reference Labs. And I did want to share a little bit of information about some of the other viruses that we're starting to see circulate just a little bit, and where you can get access to the information, at least for here in New Mexico. So I will share my screen, I hope. I can never tell if I'm doing it right, so let me know if this worked as expected.
We are seeing it.
Okay. So this is just a little bit of, I think we all know New Mexico is a large state in landmass, but low in population density. So this is just a quick population density map of New Mexico, with red being higher populations. And just wanted to point out, this was a study that was done the middle of last year or so, that just looked at the issues of access to testing. And so we talk a lot about people getting tested, but there's certainly disparities when it comes to testing access, in particular for rural communities, minority communities, and then uninsured communities. And so I think this study really demonstrated how important really being intentional about providing access to testing is when it comes to managing the pandemic. And so for the distribution of testing that we have, these are just Tricor sites, knowing that there's other places and other facilities in New Mexico that are doing testing at different levels, but just trying to just focus so everything is pretty clear and just kind of a single line of information. These are all of the places where we have Tricor COVID testing capacity, and then also locations where we've also distributed these multiplex respiratory panels throughout the state to provide faster results for viruses other than SARS-CoV-2 that are circulating, and it helps to provide a little bit of diagnostic clarity. And this is just the Albuquerque metro area zoomed in a little bit more. So we have some distribution of testing around Albuquerque. So our respiratory panels that we use here at Tricor, as you can see, they're very inclusive, and these are panels that are generally, there may be one or two target differences depending on which vendor you may use, but these are a general look at what the respiratory panels look like. So they have a variety of other viruses. We're able to subtype the influenza A's, type flu B, some different subtyping may exist around the para-influenzas and RSV. We do have the historical coronaviruses that are here, as well as SARS-CoV-2, and then some bacterial causes of community-acquired pneumonia. So there's really two approaches to this. There's these rapid panels that are random access, meaning you can test one person at a time in a very easy format. Usually they're around 2 hours for testing, but they can be quite quite expensive, both for the laboratory cost as well as for the CPT code, the reimbursed cost for insurance. And so these are really thought to be most useful when you have hospitalized patients or severely immunocompromised patients, when you need to know the answer really within those 2 hours to make a clinical, a change in your clinical judgment, a change in your clinical decision. There's smaller respiratory panels, of course, that may have now influenza A, influenza B, SARS-CoV-2, plus or minus RSV, that can be used in a more narrow setting that should be used for, the general populations. Most EDs and some urgent cares will have access to this because there's some treatment decisions, of course, around flu A and flu B, and then whether or not SARS-CoV-2 there is now, of course, going to be the question we're always asking. But for these large panels, really, we want to reserve them for the patient population where knowing if the patient has rhinovirus would make a clinical impact. And in most cases, knowing somebody has rhinovirus probably isn't going to make a big clinical decision. And so that's where we really want to think about how we're using these tests, especially these rapid panels. But then, like at our core laboratory, we do offer a batched panel that has about a 24-hour turnaround time compared to the rapid panel that's at some of our larger hospitals. And so I'll show you this graph, and then I'll show you how to access the information. So this is a graph that we have on our tricor.org website that shows all of the respiratory viruses that we detect over time. So starting in 2019 all the way to 2021, when we had this stay-at-home order that was initially released on March 18th. This was the respiratory report from that week, where we had, still a good distribution of viruses. We were just starting to see some SARS-CoV-2, but we were seeing a lot more other viruses circulating in the community. Interestingly, if you look a month later, we drop down and start to lose almost everything else. And I think it's a reflection of both masking and staying at home and all of the other things that we did, where we really dropped out of the bottom for all of the other viruses. They all really tanked, and we start to see SARS-CoV-2 do exactly what we all experienced for the entire year. And this information is available and accessible on our tricor.org website. And so I want to show you that. I think I can still be functional. Let's see if I move this here. So can you now see the Tricor website? So if you go to tricor.org, you'll be able to subscribe to the weekly report. And if you click this and fill out the information, you'll get a PDF emailed to you every Wednesday with this information. So it shows a weekly count of the viruses that are circulating, age distribution of all of the viruses overall, and then this graph that you'll be able to see. So you can subscribe to that and receive that weekly. You can also just download the PDF here, but the data is distributed weekly. What I think is really interesting is the next graph on the page. You can start to really drill down into specific viruses and interact with the data. So here's like flu A, and we can see this was the week before the public health order was released. And there's when the public health order went out. And after that, we really haven't seen any flu A for the rest of the year. Similarly, we see this with these other coronaviruses, though what we're seeing over these past couple of weeks, I think especially we can see with rhinovirus, is while rhinovirus did tank out, just about every time we do some levels of reopening, we do start to see rhinovirus begin to recirculate. And so just being aware of what's circulating about in the community, I think is really helpful. So we have this data, and then we also have a statewide dashboard. So you can look county by county and see what the circulating virus levels are in that county. You can look by county. You can look by age group. And you can also look over time and widen and narrow your time range to be able to see what's happening county by county. You can do this same thing by age group, let's say up here, and we can see what's happening in those 65 and older, or if we're interested in seeing what's happening in our school age children, we can see what's happening in our school age children here, and just really filter by viruses. So that I think is a helpful tool to really think about what's happening in the state. I'll stop my share here. One thing that we are certainly really proud of here at TriCore, I won't try to reshare my screen because one success is all I can manage, and if I tempt the fates, who knows what'll happen. But we've really been focused on making sure there was good statewide access to testing. And so when we look at what we did for testing in 2019, say for influenza compared to what we did for testing just locally here at TriCore for SARS-CoV-2, we see that actually in most counties, we overrepresented the counties in testing compared to like Bernalillo County. So Bernalillo County, we had a 14 times increase in testing from influenza to SARS-CoV-2, but in counties like Doña Ana County, where we installed a laboratory, we did 195 times more testing for SARS-CoV-2 than we'd done for flu testing in that county. Similar things we see in Cibola County, Taos County, that were really overrepresenting those counties for testing compared to what was done previously. And we know State Lab and others are also doing testing, but we're really proud of trying to get access to tests throughout the state and to counties across the state. So that's all that I have. Thank you.
Wow, thank you so much, Carissa. That is an amazing resource. You're really, really incredible. And I think the link probably went into the chat, but thank you so much for presenting that. Okay, so we have a bunch of questions. I'm going to go ahead and start. Alan Carreau was asking very early on will the state of New Mexico follow the lead of Dr. Fauci in today's New York Times and give up on reaching herd immunity? I don't know, Marla, if you want to comment on that, or anybody on the Hub team would like to comment on that.
I can start, and if anyone else has thoughts about this, please chime in. But I think our goal will be to vaccinate as many people as possible. And we're really sort of ramping up the next phase in vaccine outreach to reach the people who weren't eager to be vaccinated and lining up early on, and achieving some level of immunity hopefully will be done, via vaccine and not another spike in infections. The red to green turquoise framework was just updated last week to include some vaccine targets. And I think, with the goal of reaching about a 60% vaccination rate by the end of June, so we just put those into place last week, those new targets for easing up of restrictions. So my thoughts are early on, we're still going to be trying to achieve immunity via vaccination, keep our case counts low. I don't think that's an approach, we're going to drop at this point.
Great, thank you, Marla. Anybody else have any comments about that? Nestor, go ahead.
Yeah, no, I just want to say, no, I totally agree. The goal is to vaccinate as many people as possible. There's really, we can set a goal of 80%, 60%, 70% is a goal, but I think that the real goal is to vaccinate as many people as possible. The specific herd immunity is very difficult because it depends on many factors that affect the R naught or the reproductive number for the virus. Is, for instance, if we have a new variant that it's more transmissible, then that goal will need to be raised. So it's so variable. So I think the goal is to vaccinate as many people, and I think the natural history of the effect of the vaccine with the natural immunity, with the vaccine immunity, it's gonna actually tell us when we are there, more than saying a set number or an artificial limit. So I think the goal is to continue fighting the hesitancy and people who still are reluctant to be vaccinated, increase the coverage by including children at some point. And that's, I think, the overall goal, more than say, okay, we're going to hit 80% and then we close all vaccination and we go home. I don't think that's going to happen ever. It's just going to be sort of an accumulation of factors and seeing how the epidemic is going down as we vaccinate more people, basically. But I don't think we need to strive for a specific number. It's just a general guideline or aspirational, but I think we're gonna just continue vaccinating.
Great, thank you. Krista, did you have a comment? No? Okay. Thank you so much. There's one question about, Nestor, about from Harry Seibold about the NBA study that you showed, and he's asking, he'd be interested in seeing if there were riskier populations had could transmit the virus, because that was a very healthy group of people. I think, Harry, that's what you're asking, right?
Yeah, there's a couple of points in there that I'm asking about, whether people, we wouldn't theorize that young, healthy people would be people that would be the prolonged shedders. It's the people that have more severe illness or have comorbidities that we would theorize would have longer shedding. And have we done any studies either on those patients, or have we done any studies that use the viral culture as the gold standard? Because the NBA bubble, there's a whole lot of other things that would preclude secondary infection, not just whether or not they were shedding. So I'm not sure how strong a conclusion we can draw from the NBA, since that's not really the behavior of the general public.
Yeah, no, you're absolutely right. And there was an editorial accompanying that article that precisely commented on that this is sort of a, it's not the general population, it's a very specific population, although they included vendors. And so they were not all young, basketball players. There were also coaches of higher age and comorbidities, but obviously it's not the regular profile of the US or any other country for that matter. And it was somewhat of an artificial, they did a lot of frequent testing, etc. So it's important to point that out. There are some, I would say, some special patients that tend to have virus for longer, especially immunosuppressed individuals. There's definitely evidence that they may shed viable virus for longer than 10 days. So there have been well-documented exceptions to the rule of the 10 days, but it's mostly on patients who are immunosuppressed that they can actually still shed virus past the 10 days. Not only PCR, but actually, viable or culturable viruses. So you're right. But I think it's sort of the best we have regarding the showing that the PCR, that positive PCR, especially on a non-immunosuppressed person, probably doesn't mean transmission, at least in the majority of cases. I think it's safe to say, but you're right. There were some limitation to the study, and the fact that it's sort of a selected population, not a sample of the general population, it's important.
Thank you, Nestor. Leslie, there are a couple of questions about the change in menstrual cycle. One from David Tempest: have any other vaccines historically caused menstrual cycle changes? And another question about how long, if you have any data on or information on how long women are claiming it affects their menstrual cycle.
I have not heard of any vaccines that are supposed to affect menstrual cycle. I don't know, Nestor or Carla, if you have, but there's nothing that's coming to mind for me. And we don't have any data at all at this point is the problem. I mean, there's just tons of anecdotes of people saying, oh, my cycle was weird for 2 months after I got the vaccine, but there's absolutely no data to say, was that just sort of a normal variant, or is this actually causing problems? So that's the reason we need to study it.
Great, perfect, thank you. And then there's a couple of questions about what people's thoughts are about, or if anyone knows about what's going on in India and Brazil. Are the new variants that are causing this huge surge of infections, or is this just the original virus? I don't know, Nestor, what you've read about it.
Yeah, I've been trying to see, there are publications or pre-publication. I haven't seen that many. I've seen a lot of comments. There's a variant in India, the 617, B1617, that seems to be particular to India. They also were affected by the UK variant, but I still have not seen like a very conclusive paper on, let's say, if it's more transmissible, if it's more severe. We're just seeing this huge growth in the number of cases and fatalities there. And some of them may be associated with this new variant of interest, but I think we need probably a week. We're probably a week away from seeing more reports on this new Indian variant and some of the other variants that are circulating in India. But there's definitely a very sad situation there. And they do have this new variant, but and that variant apparently has the same immunescape mutation, the 484, that we have seen in the P1 and some of the other variants. But we'll still, I think we need a little bit more time to see at least pre-publications on the genomic studies of what's going on in India.
Thank you, Nestor. There's somebody, T. Matthew, who has their hand raised. Can you just introduce yourself? I'm not sure.
Hi, good afternoon. I'm Dr. Matthew, and because the question was raised about the situation in India, I just wanted to shed some light if needed, given I've been following that. I'm an infectious disease epidemiologist here at Michigan, and have been working closely with Manipal University. Bottom line is there's definitely a change in clinical manifestations of the second wave compared to the first wave, in speaking with some physicians on the ground there. And so I just wanted to alert everyone regarding that. With regard to the need for oxygen, it's occurring pretty soon thereafter, after diagnosis, maybe due to delay in diagnosis because the symptoms have been very vague. And therefore the oxygen requirements have gone up. And of course, everyone is aware about certain parts of India where they were not prepared with oxygen supply compared to other parts. So I just wanted to share that. And back to the point about the B1617, we really don't know what all the strains in India, because based on the government's press briefing or the NCDC press briefing, they might have sequenced only around a little more than 15,000 or so samples. So there's concern that we don't know really what's going on, and there may be variations occurring from different parts of India. So the only thing I wanted to shed light or share more information is, if there is a COVID positive patient, it's really important for us to get the travel history, also to understand from the Brazil perspective and what's overflowing to other countries, similarly from India and to the adjacent countries. Unfortunately, many places of the US, we have let down that whole travel history question. So it would be helpful, because if the person is positive from recent travel, then it behooves us to get that sample sent to the state or wherever to get sequencing done, so we can get some more idea on what's happening with our strains. Thank you.
Thank you very much for that helpful information. I just wanted to, Dan, Chris, I'm going to have you talk about Dan Saltman's question, just because I know it went into the chat for those of you who are maybe didn't read it, just to talk about the difference between the quote rapid PCR and the usual PCR test for SARS-CoV-2. Can you just talk about that?
Sure. So many of the rapid PCR tests have sensitivities that are very similar to the laboratory kind of standard PCR, but that's where it's really important. I mean, I don't think I can make that as a universal statement. Some of the platforms that we're familiar with, the Liat, the Cepheid, rapid PCRs are quite sensitive. Some of the other methods that are out there are molecular, but not necessarily as sensitive. So those that are like the LAMP methodology, which is just kind of like an isothermal reaction that doesn't require cycling, it doesn't get as sensitive. And there's so many manufacturers that are producing these rapid molecular tests right now that I don't think there's a universal answer. And I think it's just the answer is that it's very important to go into the package insert and look at the reference method in the package insert and look at the sensitivity and the performance to really understand the performance of each of these tests. Unfortunately or fortunately, I don't know, we still have a lot of tests that are coming to market with different endpoints. And if the endpoint is a infectivity CT value, then you're not going to be as sensitive as a standard PCR. So if they're just comparing to a CT value, say of 30, then maybe they'll perform fine. But if you go to a CT value of 31, 32, 33, they may not be detected. So it's really important to just look at the package insert and any data that's available.
Thank you so much. And thank you. There's a lot of answers in the chat too about the multiplex panel that Carissa talked about. So I'm not going to ask those questions. We just have a couple more minutes. I wanted to ask the question. Nurit Pat said that what I hear from many people who are hesitant to get the vaccine is that they are afraid of the immediate side effects of the vaccination, and wanting to know if other people are hearing that same thing. I don't know, Leslie, if you have any comments on that.
All right, so this is actually something I feel very strongly about, because as Nestor is every week telling me more ways I'm going to die from having had COVID last November, you know, the very rare bad side effects from the vaccine are so minimal compared to that. And even, you know, the common side effects that people are getting are fairly minimal compared to having COVID. So I personally like data, but what they have found in talking to patients who are vaccine hesitant is that anecdotes work really, really well. So I find I talk about my personal experience with both COVID and with the vaccine, and you know, talk about patients' experience with COVID. You know, I had a patient who had this happen. I have, you know, or because anecdotes really work very, very well in convincing patients. Like I said, most of us, I think, are the sort that we want to see data, but what they have found in the studies is that patients are actually going to listen to anecdotes. The other thing I find works really well is just listening to patients' concerns, because I find if I let people tell me they're worried about this, this, and this, and this, and then I say, well, I understand that, but I still recommend you get the vaccine. If they feel that I've really heard their concerns and still recommend the vaccine, that can often be very persuasive. So.
Yeah, thanks so much, Leslie. Anybody else on the Hub team have any comments about that? Nestor, anything you're hearing or? No.
No, nothing additional.
Okay, excellent. And I wanted just to let everybody know that I think it went in about 12:45, but the CME, the link to the CME went in about 12:45, I believe, if people would like to get CME credit. And also we would love to have your feedback if you can do that as well. And it looks like most of the questions actually were either answered by us or by in the chat. There was one that did not get answered. Carlotta Sanchez was just asking, she said she had any thoughts on a healthy 16-year-old female experiencing a fainting episode approximately 17 hours post second Pfizer vaccine? Has anyone seen or heard of any similar reactions like that? Leslie, go ahead.
That's the group who tends to faint after the HPV vaccine, although that tends to be more immediate, and we think it's a vasovagal. So I would think it would be similar, but I have not been seeing case reports or data on that.
Great. Anybody else have any comments about that? No. Okay, well, I'm going to go ahead and just make the announcements about the upcoming COVID-19 sessions that we have. We have a critical care session this Thursday from 8 o'clock to 9 o'clock in the morning. And our Allison Burnett, who's an amazing pharmacist who does a lot of work in the anticoagulation area, is going to talk about sort of the landscape of anticoagulation now with COVID-19. So that should be a really good talk if anyone is interested. She gave a talk about probably 4 or 5 months ago, but she's going to give an update and just discuss that. And then there's also the first responder echo this afternoon at 2 o'clock, and it's about I believe dealing. Elena, do you have it in front of you? About suicidal patients? Do you have that?
Yes, one moment, hold on.
Actually, I just found it, sorry. It's advancing treatment of the suicidal patient, integrative approaches. So that should be interesting as well, 2 to 3 o'clock Mountain Time if people are interested. So I want to thank everybody for coming today. Thank you so much to our panelists for all of their insight. And also thank you, Kent, for the librarian who put a ton of stuff in the chat that you guys can take advantage of. And I'm sorry I didn't introduce you in the beginning. So thanks everyone for joining, and we will see you next week.